Hello, wonderful viewers. Welcome back, and today we're diving into a topic that affects millions around the globe, malaria. Before we get started, make sure to hit that subscribe button and ring the notification bell so you never miss out on our medically approved content. Malaria is an ancient and continuously unmatched parasitic cause of human suffering throughout the world. Transmitted by a female Anopheline mosquito. Anopheles mosquito requires the protein from a blood meal to produce its eggs. When protein for egg production is required, the adult female is attracted to many chemical indicators of human activity, CO2, lactic acid, odors, and moisture. Typically, they feed at night or in the late evening or early morning. Plasmodium species, an obligate intracellular protozoan using the mosquito as its vector, permeates the tropical and subtropical world. For common Plasmodium species of concern to humans: Plasmodium vivax, Plasmodium ovale, Plasmodium falciparum, Plasmodium malaria. There is a fifth in Southeast Asia that rarely can infect humans and cause severe disease, Plasmodium knowlesi. Stages of infection. Infection occurs during the mosquito's blood meal as the female Anopheles inserts her proboscis into human skin and injects sporozoites with her saliva. Sporozoites reach the bloodstream and reach the liver, where they must cross the sinusoidal barrier to access and invade their target hepatocytes. Exoerythrocytic schizogeny, liver stage. In the liver, the sporozoites mature into spherical multinuclear schizonts. After 5 to 21 days, each liver schizont ruptures into thousands of uninucleate merozoites. Erythrocytic schizogeny, blood stage. Each merozoite may infect a red blood cell. They feed off hemoglobin within the erythrocytes, with the parasites first appearing as ring forms, then forming trophozoites. Hemozoin is a brown pigment biocrystal waste product. Trophozoites again mature into schizonts, which rupture into merozoites, thus continuing the erythrocytic or blood stage. Some trophozoites mature into sexual stage gametocytes rather than schizonts. These male and female gametocytes then may be ingested by another feeding Anopheles mosquito. Sporogony, mosquito stage. Male and female gametocytes ingested by a mosquito undergo sexual reproduction in the gut of the mosquito, producing motile eukaryotes, which invade the wall of the mosquito midgut, forming oocysts. The oocysts subsequently rupture, releasing sporozoites that invade their way to the mosquito's salivary glands and await a new human host. All clinical manifestations occur due to erythrocytic schizogony and host's reaction to them. Exoerythrocytic schizogony do not contribute to clinical illness. Species-specific features. Plasmodium vivax. Typical incubation period, 8 to 17 days. Classic fever periodicity, 48 hours. Called tertian malaria. Both vivax and ovale are known to variably enter quiescence after hepatocyte invasion. Can cause relapsed infection despite treatment of the patient with schizonticidal agents. When suspected, the affected patient must receive presumptive anti-relapse therapy, PART, with primaquine or tafenoquine to target the hypnozoites. Vivax infects reticulocytes preferentially via the Duffy antigen present on red blood cells. Ethiopia, India, Indonesia, and Pakistan account for most cases. Plasmodium ovale. Typical incubation period, 10 to 17 days. Classic fever periodicity, 48 hours. Like vivax, ovale also produces hypnozoites in the hepatic phase of its life cycle. Ovale typically produces a milder infection compared to falciparum or vivax and may self-resolve after 6 to 10 paroxysms. Plasmodium falciparum. Typical incubation period, 8 to 11 days. Classic fever periodicity, 36 to 48 hours. Called as falciparum malaria, malignant tertian malaria. Most virulent and causes more severe disease, Plasmodium malaria. Typical incubation period, 18 to 40 days. Classic fever periodicity, 72 hours. Called as Quartan malaria. Unique syndromes and mechanisms. Plasmodium malaria infections typically cause lower parasitemia and account for a minority of the malaria burden in the world. Infection also is associated with proteinuria and membranoproliferative glomerulonephritis secondary to immune complex deposition. Plasmodium knowlesi. Typical incubation period, 9 to 12 days. Classic fever periodicity, 24 to 27 hours. Called as quotidian malaria. Plasmodium knowlesi is a simian malaria that has been found to cross into humans in Southeast Asia, particularly on the island of Borneo. It resembles P. falciparum in early erythrocytic stages, and as it matures it resembles P. malariae on microscopy. This unfortunately puts the patient at risk of being diagnosed with a less severe infection. Patients with malaria can have hepatosplenomegaly. All patients with malaria present with headache. Also, cough, fatigue, malaise, shaking chills, arthralgia, myalgia, weakness, paleness, dizziness, abdominal pain. Less common malarial symptoms include anorexia and lethargy, nausea and vomiting, diarrhea, jaundice. Infected patients experience a febrile paroxysm. It occurs in 3 stages. Cold stage, initially, lasting 15 to 60 minutes, with intense cold and uncontrollable shivering. Then the hot stage, 2 to 6 hours, intensely high fever, severe headache, nausea, vomiting. Finally, the sweating stage, the patient is drenched in a profuse sweat, and the temperature drops rapidly. Fever periodicity, which was mentioned earlier, occurs with synchronous rupture of mature schizonts, not generally seen in falciparum. The occurrence of periodicity of fever is not a reliable clue to the diagnosis of malaria. Severe malaria primarily involves Plasmodium falciparum infection. Severe malaria manifests as cerebral malaria, severe anemia, respiratory symptoms, and renal failure. In children, malaria has a shorter course, often rapidly progressing to severe malaria. Children are more likely to present with hypoglycemia, seizures, severe anemia, and sudden death, but they are much less likely to develop renal failure, pulmonary edema, or jaundice. Cerebral malaria can present as hallucinations, confusion, and coma. Severe anemia. The anemia associated with malaria is multifactorial. In non-immune patients, anemia may be secondary to erythrocyte infection and a loss of infected RBCs. In addition, uninfected RBCs are inappropriately cleared, and bone marrow suppression may be involved. Renal failure. Infected erythrocytes adhere to the microvasculature in the renal cortex, often resulting in oliguric renal failure. Also, as there is intravascular hemolysis occurring, this can present as dark urine. Respiratory. Patients with malaria may develop metabolic acidosis and associated respiratory distress, and pulmonary edema can occur. Signs of malarial hyperpneic syndrome include alar flaring, chest retraction, intercostals or subcostal, use of accessory muscles for respiration, or abnormally deep breathing. Assessing malaria. Investigations for malaria should be performed on anyone who has traveled from or through an endemic malaria area within 3 months of arrival, if asymptomatic, or within 12 months if symptoms of fever, regardless of any pre-departure malaria testing or treatment. Suspected in any patient presenting with fevers greater than 99.5 degrees Fahrenheit in an endemic area without other obvious cause. Malaria should be suspected in children if they present with anemia and hemoglobin of less than 8G/DL. Results from routine investigations can include: a complete blood count can show decreased HB, increased indirect bilirubin, and increased reticulocytes as hemolytic anemia occurs. Glucose assessment can show hypoglycemia. Serum creatinine and urea can be elevated if AKI has occurred. An ABG can show acidosis. Urinalysis can show hemoglobinuria due to intravascular hemolysis. G6PD screen must be done if considering primaquine treatment. Consider a septic screen if unwell. A chest X-ray if respiratory symptoms are present, and CT scan of the head may be obtained to evaluate evidence of cerebral edema or hemorrhage. Rapid diagnostic tests. Immunochromatographic tests, based on the antibody to parasite antigens, PFHRP2, parasite LDH, or Plasmodium aldolase. detects P. falciparum with greater than 90% sensitivity but insensitive for other species or low level of parasite. In addition, new molecular techniques such as PCR assay testing and nucleic acid sequence-based amplification, NASBA, are available for diagnosis and species identification. They are more sensitive than thick smears but are expensive and unavailable in most developing countries. Blood smears allows for visualization of parasites within RBCs via microscopy to confirm malaria diagnosis. 3 thick and thin smears 12 to 24 hours apart should be obtained. A single negative film or antigen does not exclude malaria. Thick and thin films should be repeated with fever spikes until a positive test or 3 negative films. Thick blood smear, high sensitivity, best initial test. Examine larger blood volume and detect malaria parasites. Thin blood smear, lower sensitivity, high specificity. Confirmatory test. Species identification and calculation of parasite. The findings that can be seen. Schaffner granules, fine, brick red dots, within RBCs infected with vivax and ovale. In vivax, enters only reticulocytes. Single parasite in an RBC. Infected RBCs enlarged. Round gametocytes. Falciparum, found in all RBC stages. Multiple parasites are found in a single RBC. Crescent-shaped gametocytes. Plasmodium malariae, band-like trophozoites. Now we move on to management. Patients meeting the criteria for severe malaria or with P. falciparum infection initially should be hospitalized until their condition improves and there is a noticeable decline in parasite. P. falciparum or species not identified from areas with chloroquine resistance. Artemether/lumefantrine. Atovaquone/proguanil. Quinine, extended duration if infection acquired in Southeast Asia, plus doxycycline. Doxycycline is preferred, but tetracycline or clindamycin also are options. Mefloquine, not recommended in certain regions of Southeast Asia due to resistance. Plasmodium falciparum from area without chloroquine resistance or other species not identified, vivax, ovale, malariae, knowlesi. Chloroquine. Hydroxychloroquine. Any regimen listed for chloroquine-resistant P. falciparum malaria. And follow up with primaquine for vivax or ovale or unknown species for hypnozoite eradication. Vivax malaria with known chloroquine resistance. Artemether lumefantrine as above for uncomplicated P. falciparum. And primaquine. Severe or complicated malaria. For artesunate is more effective than for quinine. Maintain strict fluid balance, avoid fluid overload, cerebral/pulmonary edema. After the initial course of 4-artesunate, the patient can transition to a full course of oral artemether/lumefantrine if parasite is reduced to less than 1% and the patient tolerates oral therapy. Followed by primaquine. Pregnant women, especially primigravid women, are up to 10 times more likely to contract malaria than non-gravid women. Gravid women who contract malaria have a greater tendency to develop severe malaria. Pregnant women with malaria are at increased risk for severe malaria, severe anemia, and delivery of a low birth weight infant. Medications that can be used for the treatment of malaria in pregnancy include chloroquine, quinine, atovaquone proguanil, clindamycin, mefloquine, sulfadoxine pyrimethamine, avoid in first trimester, and the artemisinin. The risk of contracting malaria depends on specific areas visited within countries, season of travel, style of travel, length of trip, drug resistance patterns, individual medical conditions, and the local medical infrastructure. In general, Africa and Oceania present the highest risk. Asia and South America moderate to low risk, and Central America is very low risk. Choosing a preventive strategy. All travelers to tropical areas should practice anti-mosquito measures, and where malaria transmission exists, where significant risk exists, chemoprophylaxis should be considered in addition to routine anti-mosquito measures. 4. Destinations of moderate risk, factors such as length of stay, accommodation, medical history, and likelihood of compliance impact significantly on the decision-making process. For mosquito bite prevention, insect repellent containing adequate amounts of DEET, light, loose, and long clothing, and mosquito nets. For those at high risk of exposure, permethrin can be used to impregnate mosquito nets and clothing. For chemoprophylaxis, 3 medications are currently used by the majority of travelers: mefloquine, doxycycline, and atovaquone. We conclude today's exploration into the world of malaria. Share this video with your friends, family, and community to spread awareness and contribute to the collective effort in eradicating malaria globally. Stay informed, stay vigilant, and let's work together. Thank you for joining us today, and don't forget to subscribe for more informative content on health and well-being. Until next time, stay healthy, stay safe, and take care.